Good to go?
Yep, you should be good. All right, Mark,
Okay.
take it away for nursing.
All right. So this is the nursing portion of the town hall. We want to talk about some changes that have been happening as we transition over to new ownership in the wake of all the staffing challenges that we've had that have been brought on by COVID-19. Um, there will be some ongoing changes with how we staff the facility. It's no news that we need to eliminate agency. While we are grateful for the help we have gotten from agency, nurses and STNAs, we are doing our best to transition to making sure we have our own staff, and our goal is to eliminate using agency. As you heard last town hall, uh, there's no plan to eliminate jobs, but we do need to alter some of the ways we do things and some responsibilities, and need to redistribute the workload. This is already in the planning stages, and some of this will be completed in the next couple of weeks. Other changes may take a little bit longer to implement. Changes are not set in stone. They will be fluid. We may make changes and change things back as we see what works best for the facility. We continue to search for and interview and hire new nursing staff. We recently had, I think, 4 nurses in the last orientation, which is great news. As we get new nursing staff in, it's critical that we welcome people and make sure they know that we are happy they've joined the team. Nobody wants to feel unwelcome. Imagine if it was you walking into a new facility for a job. We want to make sure our new staff does feel welcome. So please be helpful and be kind. Some other updates. So, new bonus rate offers for nurses and STNAs went into effect on February 21st. Everybody should have received a blast. It went out on shift. Going forward, PRN staff will receive bonus amounts only after the PRN requirement has been met. So, just to reiterate, the PRN agreement is to work 1 shift per week, 1 weekend per month, and 1 summer and 1 winter holiday. There are still full-time and part-time STNA and nurse positions available, and at a better rate than the PRN rate. See myself or Peggy, Steve, or Marissa if you are currently PRN and would like to have a steady schedule. So some STNA reminders, ones that I'm sure you have heard before. POC charting is to be completed before the end of your shift every time you work. As a reminder, on the long-term care units, the Cardexes are hung in the rooms. On CCU, the Cardexes are inside the wardrobe door. On MCU, they are hanging in the bathrooms beside the mirrors. There are bifold doors to the closets on MCU, and so they are hanging next to the mirrors. SCU, the Cardex is printed by your nurse, but there's a binder at each charting station. Charge nurses keep these updated. It is important to look at the Cardex every time you work. Huddles are to be done at the beginning of each shift after nurses get their report. If a nurse doesn't offer huddle, make sure you ask for it. That's communication. We have to work together on that. Showers need to be given as scheduled, and the shower sheets need to be filled out by the nurse and STNA and signed. As skin checks are completed at the same time, it's important to catch any skin changes early. So STNAs, nurses should be working together. Hopefully shower sheets are being passed out at the beginning of the shift, and you're working together to make sure that when the shower is given, the nurse is also looking at their skin. We want to make sure that we have residents up and dressed and ready for breakfast so that meals can be served hot and on time. So some points on hygiene and safety. Unless otherwise specified on the Cardex, toileting or check-in changes are to be done a minimum of every two hours and PRN. Some people require it a little more often than 2 hours, but that is the bare minimum that we should be doing check and change on people. Um, Toileting can be done during tray pass and tray pickup and during meals. You're wearing gloves. When you are toileting somebody, you obviously are going to wash your hands afterwards. We don't want to tell people that need to be toileted. We never want to say, I can't right now, I'm passing trays, because then we're making a tray of food more important than a resident. And we have to remember that residents, we are here for the residents. So if somebody needs to be toileted and you're collecting trays, you do need to stop that task and get with the resident to address their needs. Catheter care is done each shift, and we need to make sure that we are documenting urine characteristics such as cloudy, whether it has sediment, any foul odor or color, or any change in the Foley bag. For example, a purple or blue tone. Things like that need to be reported to the nurse immediately and followed up on. Bags are to be emptied before they are full, and the amount reported to the nurse. Briefs or pads must be in a single layer. We do not want to double brief on a resident. It's not good for the resident's skin. Safety rounds are to be completed when you come onto your shift before huddle. Uh, Throughout your shift, you should be checking on your residents and prior to leaving, ensuring that all beds are in proper position, all safety devices are in place and in working order. Definitely remember and follow the Cardex. Residents' personal items are to be placed in a blue bag and then put in the white barrel in the dirty utility for laundry to pick up. Linens, pads, washcloths, draw sheets are to be rinsed if heavily soiled and bagged and tied, and then go into the big bag in, go into a big bag in barrel in the dirty utility, and these bags get emptied down the chute at the end of your shift. Please make sure bags are tied. We have had issues with loosely tied bags going down the chute, and it does create quite a mess. So some more info on survey prep. Please remember that in the community, of course, people are not out to breakfast wearing a gown. We want to make sure that residents are appropriately dressed at all times. If a resident doesn't have sufficient clothing, there's an area near MCU, the laundry down on the MCU, where clothing can be obtained. Some residents come in with very little clothing. We want to communicate with family to see if more clothing can be brought in, but if they do need something, we most likely will have something that fits just about everybody. If a resident prefers to wear a gown, we need to make sure that they are covered and that there are no gaps. We can put one gown on the front, one gown on the back if we need to do that. Um, and we need to care plan that. So if a resident gets food or liquid on their clothing during a meal, they need to be offered to be changed afterwards. We don't want to let somebody sit there at lunch when they still have breakfast that they might have spilled on their clothing. If a resident has a wet or soiled brief or undergarment, we should not be serving them a meal until their clothing is changed. If they refuse, that's their choice. We need to let the MDS staff know that so they can care plan that and let the responsible or interested party know. Remember, we want to make sure that our residents are shaved with their nails cleaned and trimmed, and this should also be offered on shower day and PRN. It's important that we are wearing our badge in a way that it is visible to the resident. We want to make sure we're knocking on the door, waiting for permission to enter, and let the resident know what care you'll be providing. That's something we have had some complaints about, that people enter the room and just start working on a resident without really addressing them. You want to address them, let them know what you're about to do, and they do have the right to know who is taking care of them. So your badge does need to be displayed so that they know who you are. Even better, introduce yourself, by name. So the next portion is for nurses only. Want to make sure that catheter care is getting done on your shift and that you're looking at the urine in the bag, noting any changes in color, um, and notifying the doc or the nurse practitioner and the family member of any changes. Urine dips are our protocol. We don't need to complete a UA-CNS for every patient. We don't need an order to dip the urine. We can dip urine first and report the results to the CNP to find out if they want further orders. Urine dips and UAs need to be an actual clean catch or a straight cath if there's no catheter. So if a resident has a catheter, a new catheter must be inserted and specimen needs to be obtained from the new system. You can't change the bag to obtain a specimen. Remember that dehydration can cause confusion and dark urine as well, so make sure residents are drinking enough. Controlled medication counts to be done with both nurses viewing the count sheet and agreeing on the number. The card count sheet must also be signed oncoming and offgoing nurses. So both nurses need to be looking. I know that what most people do is the new nurse comes on and is looking and counting the meds in the cards, which is accurate. But that nurse who is going to be taking those keys needs to also be looking at the log to see that if a nurse offgoing is saying that there are 17 Norco and there are in fact 17 Norco in that card, you want to make sure that that is the number that is written there, that someone isn't misspeaking or making a mistake, because you are taking responsibility once you take those keys. Remember, you must sign off meds when you take them from the narcotic box at the time you remove it, not at the end of your shift when you're counting. This happens from time to time, and then it kind of holds up the count, and the count is wrong, and then a nurse is remembering that she forgot to sign off in the binder. So that is to be done at the time you remove the narcotic. Pre-pouring is never acceptable. Every resident's medications should be prepared individually. And remember also that all medications should be dated when they're opened and discarded appropriately. Aerosols, foil packets, insulins, all of that has to be dated. Chart checks, glucometer checks, fridge temp logs, wheelchair washing, med cart cleaning and maintenance are all night shift responsibilities, but all shifts need to take orders off on their shift and make sure that the med rooms and med carts stay neat and clean. You should leave your shift with a clean and tidy med cart for the nurse that's coming on. As far as discharges go, packing resident belongings and discharge summaries are to be completed by the 11P to 7A shift the night before discharge. 3 to 11 staff calls in meds to the pharmacy the day before the discharge. 7 to 3 shift compares the med list on discharge summary, prints out the discharge summary, reviews with the patient and the family, and has them sign and give them a copy of the discharge. Meds are not to be sent home with skilled patients. Weights and vitals are to be obtained as ordered and are not entered into PCC by the STNAs. You should be giving that information to the nurse and they should be entering it into PCC. Skilled charting is to be completed every shift. And for nurses that work 7A to 7P, they do need to do skilled charting twice. Even though they are working only the first half of 3 to 11, they are responsible for charting twice when you're working 12 hours. Falls charting. This also needs to be completed for 72 hours every shift during that 72 hours. And there is a batch order to enter that. If you do a search in the order search field, if you just put in 7-2, that batch order will pop up and it's very easy to put that order in. Supplements are delivered as ordered and the amount and percentage consumed should be recorded in PCC.
Mark, I think that's the last slide.
Oh, that was okay. I thought there was one
Yep.
more.
Anything additional for the group?
I think we covered everything.
All right. Thanks everyone for listening in. And again, a reminder to complete your quiz for the town hall portion and to complete your TB.
Thanks, everybody.
Thanks.